conclude the conference by having just brief conversation with Arthur Rubenstein, Jordan Cohen, and myself about the Bucksbaum Institute. I've introduced Dr. Cohen, who gave the keynote talk, and let me just say a few words about Dr. Rubenstein, who is professor of medicine at the University of Pennsylvania. For many years, Dr. Rubenstein was my boss and mentor and leader when he served as chair of medicine here at the University of Chicago. When he left here, Arthur went for 4 years to be dean at Mount Sinai School of Medicine, where he was the Gustav Levy Distinguished Professor, and then he went on for 10 or 11 years to be the dean of the University of Pennsylvania Perelman School of Medicine. Dr. Rubenstein is an internationally renowned medical leader, as well as an endocrinologist who's been recognized for both his clinical expertise and his groundbreaking research in diabetes. So I'm going to invite Jordan and Arthur to come up to the table, and we'll sit there for a few minutes. As we said at the beginning, I said briefly, the Bucksbaum Institute is in its 7th year. The goals are to improve the doctor-patient relationship and communication and decision-making between doctors and patients. You've heard today from master clinicians at the Institute, from senior scholars, junior scholars, and medical student scholars. We've, as I said early on, overall, we've appointed about 300 scholars in total. Now, 100 of them are undergraduates in something called the CEST program, Clinical Excellence Scholar Training, for pre-medical students over at the college. But about 180 to 200 are here at the medical center in the hospital. And our hope and goal is that the people we appoint both are themselves representative of the kind of doctors we hope to train and prepare in medicine, and also not only themselves acting that way, but mentoring for other physicians and students. And that has been our hope and expectation over the years. The advisory board has been extraordinary in helping us, Dr. Rubenstein, Dr. Cohen, and the third external member of the board is Dr. Laura Roberts, the chair of psychiatry at Stanford, who couldn't be with us today, but is very much involved in our activities.
Anything?
How are we doing?
I always come here and I'm very impressed by, first of all, the presentations, and then Mark and Angela sent out a summary of what the Bucksbaum Institute is doing. And of course, I was here many, many years watching Mark's programs in a variety of areas of ethics and clinical care evolve. At one level, I think, to be honest, one can be pessimistic about the healthcare system. It's $3 trillion, and, we seem to be fighting a tsunami, really, of money and physician lack of empowerment and so on. But, I think all really important movements, when they start saying enough, begin in a small way. And certainly the Bucksbaum Institute and the Arnold P. Gold Foundation, that Jordan is the vice chair of the board, and a number of similar organizations are really starting to push back and say, as in Jordan's excellent lecture, this is not a way that medicine is going to thrive, or that patients will get a good deal, or that physicians won't suffer burnout. I think one of the real questions that we underestimate is the question of time, or maybe we don't underestimate it, but it certainly, in my view, figures very, very strongly in many of the issues that we struggle with. And I just want to say that in the most recent JAMA, I think it came out this week, there's an article by the dean at the University of it's in Reno, Nevada, I guess. University of Nevada Medical School at Reno. There are two there now. His name is Tom Schwenk. And he wrote a viewpoint in JAMA, which in a page and a half, I thought, wow, I wish I'd written that. It encapsulates beautifully what had gone wrong, in a very, very complex analysis that many of these presentations today and many of the work pioneered here is dealing with. And what he said, and I really would advise you all or suggest you all read it, it's just very, very impressive. He said, the way that physicians and patients always got the best out of each other. So physicians found the best in terms of patient care, as Jordan began with Peabody's statement. And the best way that patients responded to physicians in terms of what they could do to be helpful or supportive was to get to know each other and to benefit from the interpersonal reactions that take place in the patient-physician relationship microcosm. And at the moment, there are just 100 factors that seem to get in the way of that, whether it's the electronic medical record, whether it's 15-minute appointments, whether it's RVUs, whether it's this or that. This kind of, I wouldn't even call it leisurely, this ability to spend enough time interacting with the patient and their family, if necessary, and find the kind of joy in understanding the impact of each other, and then being able to suggest something that may be helpful, or certainly being able to be empathic and helpful. That's at the core of, I think, what we've done for hundreds and hundreds of years. And the current system, whether it's money, time, organization by bureaucrats as business, has got in the way of that. And that, I think, has really damaged all the things, or many, many of the things we hold dear. So we need to start fighting back, as we are, in a small, systematic, but definitive way, using patients or interacting with patients as our colleagues, as our, we're in it with them together, and saying that although this is business-like, as Jordan said, it's not business. It's just not possible to do the kind of things we hold dear as Dr. Watson or IBM or that. There just isn't the ability to do it that way. So I want to say I think Mark and his leadership and the Bucksbaum Institute and the programs that preceding it, have set the stage for the opportunity that we now as a collective group should fight back and try to find a way with some objective data, as Jordan pointed out, to say this is not a positive outcome to deliver medical care in this kind of way. And, maybe in 10 years or 20 years, this whole thing will have changed around. And I certainly have always been an optimist, and I think we should all, use the ability we have as presented in these rather beautiful talks today to really push ahead with that kind of approach.
Well, I just want to, first of all, associate myself with everything that Arthur said. He's my mentor, so I have to agree with him. But I do, in fact, agree with him. I think one would hope that some of the frontline soldiers in this battle that we're going to have to do with the system are going to come from the University of Chicago and people who have had an experience with the Bucksbaum Institute and the kind of things that you're doing. And I'm going to take a risk here and sort of turn the tables and ask the audience. The Bucksbaum Institute has now been in existence for 7 years. They're about to engage in a thorough evaluation of the impact of the program on the institution. I'm looking forward, obviously, to the outcome of that. But as a preliminary effort, would anybody like to say what they think the Bucksbaum Institute has actually contributed to the culture of the University of Chicago? Do you feel it in any meaningful way in what's happened here over the past half a dozen years? Anyone brave enough to say yes?
I think what it, at least from my point of view, it seems to fight the overwhelming administrative policy here, in which a lot of, I think, the joy for medicine for many of us is gone, because the RVU system is now at the front, the most important thing that can be accomplished here. And I was actually accused of spending too much time teaching patients. Why didn't I have more brochures in the office? I said, well, these people are quite intelligent. They usually come to the internet and come to us asking questions already. And they still instill these humanistic values at a stage where they need to hear that, because they get into the clinics and it really gets destroyed. And most of the articles, New England Journal and other places, talk about residents actually having contact with patients 20% of the day. More than 50% of the time they're in a computer. And they keep telling us now, not only are we putting in the patients, we're putting in billing, we're taking the jobs of other people because they can do it, and it's getting us out of the whole realm why people go into medicine in the first place.
I think that the institution and the Bucksbaum Institute have a unique opportunity, because looking at from the medical student experience on up, it's clearly an awakening and a mindfulness about what the values of the medical profession really should be. And the Bucksbaum Institute should take this back to the institution in a very forceful way about what they think should be done with regard to either education, expectations, focusing resources, faculty burnout, faculty satisfaction, not so much to blow a horn alone, but just to really make the institution aware at the highest levels what are the priorities seen by the members of the Bucksbaum Institute. Because I think that's a very helpful thing to do. I think there's a lot of recognition about the value of it. There's evidence for what people are achieving, but if it stops there, then it doesn't actually make the next step.
I'm going to challenge you. I just thought of it when Arlene spoke. So why don't you suggest to the powers that be that run the place, and same as at our place, everyone, it's not unique here. In fact, for full disclosure, I had to impose RVUs. I hate to say it. Why don't you do a randomized study here where you challenge the leadership that one clinic, or, you'll have to think it through, does business as usual, 15 minutes, billing, electronic medical records, same as most places are doing. And then you have another clinic that puts in the principles of the Buxbaum Institute, humanistic care, professionalism, empathy, all the things we are arguing for. And then do some kind of study, I haven't thought of the outcome, where we compare patient satisfaction and money and physician burnout. Try to look at this so that we can stop talking about it and just say, we say we right, and they say, well, there's nothing we can do about it. That's going on for now a long time. But maybe if we did a really, really important study and thought about it, those of us who believe in it, we could do something objective that we would say, look, when you do it this way, maybe the money went down 10%, but look at all the things that went up 20%, whatever they are. So I think we should stop talking and do something.
I think it's a spectacular idea. We could model it after several of the talks we heard this afternoon, Jordan's, Arlene's, Nada's, and Robert's. I have a feeling, and this is not a criticism of the powers that be, but is the door closed? But I have a feeling that to do that study, a controlled, randomized study, it would be essential that we raise the money in advance to pay for the RVUs that we lost in doing the study.
Well, you raise a lot, you'll get a donor too.
Now, there is there is one model that Arthur and Jordan and I will remember. Looking around the room, there aren't too many others who may recall it, but the height of American managed care, I mean, the peak, was in the late 1980s to about the year 2000. And I mean, you couldn't turn around without getting administrative permission, to do anything, to refer a patient, to order tests, to prescribe medicines. I mean, managed care was clearly in control of the system. And the American public, along with the doctors and nurses, but it was more the American public who objected to that model and frankly rejected it. And it was overturned. And whether it is now on its return, back to those days, but at least for 15 or 20 years, we saw the public rejecting a system that they found unacceptable and intolerable, and the doctors and nurses were entirely with the public on that one. And I wonder if the time has not come to try that again.
Let's try.
I think there was another comment here.
I've been on the faculty for 5 years, so Buxbaum's been around longer than I've been on faculty, but I can say it's created a culture for me where I can find colleagues outside of my own department to collaborate with. And it also validates, I think, those of us that are interested in studying the humanistic sides of medicine that maybe wasn't there before the Institute was founded. So.
No, I think Arthur's idea about trying to actually get some more data that would document the advantages to the institution of having a mode of healthcare that was more humanistic and more patient oriented. I mean, the lip service is there when we talk about patient-centered care. I mean, what is patient-centered care? It's centered on what the patient needs, and what the patient needs is a caring caregiver who can, in fact, relate in a human way to the ordeals and the aspirations and the problems that the patients are facing. And you say you're going to have to find some money to offset the RVU loss. I'm not sure there'll be RVU loss, frankly. I think if the compliance with medications and with other recommendations is higher, if no shows fall off, if you've got better participation in the various programs that you're doing, I think that redounds to the bottom line in a very definite way. So I'm not sure that it's going to be necessary to support it financially. It's really getting the commitment on the part of the caregivers to ensure that they take the time, that they don't use the clock to figure out how long they had to pay with the patient, and if there is a fall off in patient census, there has to be some approach to that, some offsetting abilities to deal with that. But my guess is that it will not be. But it's worth a try. It's worth a try to see whether you've got a system that you could put in place that's going to in fact document the advantages that accrue from it.
I'll make one other comment, and if you quote me, I'll deny it. So it'll be fake news, so don't do that. So I've been impressed, with all this thing about physician burnout and depression. These are very real things. So we're struggling, as a profession appropriately, how to deal with this. I mean, it's a big, important issue. So the way many places are dealing with it, I'm not going to mention names and so on because that would be the end of me, but, they're putting in childcare, which is a good thing, lounges for physicians to talk to each other, it's a good thing, cafeterias where we drink coffee together, how can you say that's not good? Basketball games, on Saturday together and when I talk to the faculty, they say that's all great, but you know what we need? We need help in our clinics to take care of patients better. We need longer times. We need more nurse clinicians, physician assistants, people that help us with the electronic medical record. What we need is the ability to go back and look after patients the way we know that it's good for them and us. And all these other things are fine. You know, they're like icing on the cake. But they don't actually, in my view, come to the heart of the problem. Now, why do they do that? It's because it's cheaper than changing all this outpatient healthcare system. So they rather put it, I don't mean it in a bad sense, but I think it doesn't come to the heart of the problem, which is how do you get the greatest joy and satisfaction, and how do patients respond in a way that is the way they used to our care and their families, that gives us joint rewards. And that requires a whole new thing. So if you do the study and show it, you can acknowledge me in the acknowledgements.
Oh, I will. Olwen and Rex, can we do it in oncology and orthopedics, you think? What? I won't challenge you to that right now. But I very much want to thank our speakers today. I want to thank Jordan and Arthur for their work on the board, and all of you for coming this afternoon. And of course, Angela Pace-Moody. Angela, please. Who put the entire program and institute together. We have an enormous regard and thanks. So thank you very much. Bye-bye.